Hello dear aspirants, welcome to KNO Academy. So in this class I am going to teach you some of the image based questions very important for the upcoming NORCET. Okay, so NORCET always focus on the ICU, emergency and OT. Okay, so many questions will come from the OT, ICU and emergency. Okay, so don't ignore the topics. Okay, so last time they have asked ambu bag parts and also ambu bag holding techniques. Okay, this time they may ask the ET tube parts. Okay, so we don't know, so that's why I'm going to explain in this class. Okay, so first we will see the ET tube. So ET tube, this is a cuffed ET tube. We can see here cuffed ET tube. Okay, so who are all passed in the 2025? Okay, they may not know this. Okay, maybe who are all working in ICU and all, so they know the ET2 parts, everything. Okay, so very important points only I am going to explain here. So here we can see this is the cuff. Okay, this is the cuff. So we are inflating from here. Okay, that cuff pressure, everything I am going to teach you. Don't worry. Okay, so this is the pilot balloon. What we call, this is the blue color is there now. This is the pilot balloon. Okay, so this we are inflating through the empty syringe. Okay, so this is the inflated balloon. Okay, why we are inflating the balloon? To prevent the aspiration and to prevent the air exit. Okay, and here we can see Murphy's eye, that is the small hole will be there here. Okay, that is the Murphy's eye. Murphy's eye, why we are using, I will tell you. So this is the main hole. Okay, for the ET tube, this is the main tube. Okay, so this will fix in the trachea and the air will go to the both lungs. Okay, suppose if this area blocks. Okay, suppose this area blocks. Okay, this, from this area the oxygen is delivering. Okay, so that's the reason only we are giving the Murphy's eye on the ET tube. Okay, so and here we can see there is a radio opaque line. This blue color line is there now. This is the radio opaque line. Why they have inserted the radio opaque line? Just because of X-ray. Suppose if we are taking the X-ray, okay, after intubation, so we can easily identify that where the exactly ET tube is situated or ET tube is fixed. Okay, so whether it went to lungs or it went to trachea, sometime it may go through abdomen also. Okay, for that reason, to identify or to confirmation the position of the ET tube, we are taking the X-ray. Okay, so for that reason they have inserted the radio opaque line in the ET tube. Okay, and this is the depth marking of that centimeter 21, 22. Okay, where we are fixing the curvature of the mouth, so where we are fixing, so that is the number of the centimeter we are marking. So that we have to write it in our nurse's note, because after intubation we are fixing at 20. Suppose we are fixing at 21 centimeter. We are fixing at 21 centimeter. Suppose tube may displace. Okay, so it may come up to 20. Okay, while we are giving handover, it may 21. Okay, but after some time you will see it is 20 centimeter. So that is the reason. Okay, maybe tube may be pulled out. Okay, or sometime we are pushing the tube inside. So to confirm that, okay, we need to mark always, that is the which centimeter. Okay, at which centimeter we have fixed, that should be perfect. So this is the cuffed ET tube. So don't forget, this is the cuffed ET tube. If you see this cuff, this is the cuffed ET tube. Okay, we'll move on to the next image. This is the uncuffed ET tube. Uncuffed ET tube. Okay, this is the uncuffed ET tube. So this is used for the pediatric patients or kids. Okay, why? Because their trachea is very small. Okay, to prevent the injury with the cuff. Okay, we are giving the uncuffed ET tube. Okay, that is enough. Okay, next image, Murphy's eye. Okay, I told you now. So this is the, see, this is called Murphy's eye. Okay, I have marked in the blue color. This is the Murphy's eye. So this is the inflated tube. Okay, this is the main hole. Okay, so air will enter to the lungs from here. Suppose if this blocked, okay, we can see the air will deliver from this. Okay, so this is the Murphy's eye, and we'll see this is the subglottic. Okay, subglottic ET tube. subglottic ET tube, subglottic suction. Okay, so this one, see, we can see in the first 82, we saw only, see here we can see, we saw only here pilot one, only one pilot balloon from here. Okay, only one for the inflation of the balloon. But here we can see there are two tubings are there. Okay, here see, this is the one and this is the two. There are two tubings are there. So this is the pilot balloon here. This is the pilot balloon. Okay, and this is the subglottic suctioning port. This yellow color is there the subglottic suctioning port. I will tell you how. Okay. Suppose from the ET tube suctioning directly we are inserting the suction catheter from through the ET tube and we are sucking from the any secretion from the trachea from here. Okay, from here we are dead. But what about this area secretion? Okay, that is the outer part of the ET tube. That is the subglottic suction. Okay, so from okay here hole will be there. From here, if you are doing suction means okay secretions, water secretion, okay, secreting outside the ET tube will come through this. Okay, hope you understood. Inside the trachea, we are taking from the main tube. Okay, from outside the trachea, if any secretion is there means we are taking from the subglottic suction. So for this advanced ET tube, okay, they have called subglottic suction ET tube. Okay, so hope you understood. And this is the RAE tubes, RAE tubes, ring, Adair and Elvin. So these are the scientists. Okay, they are the scientists who discovered these tubes. Okay, north facing, south facing. So this is the north facing. So this is already labeled. Okay, this is the south facing. This is the south facing. Okay, so why we kept north facing and south facing? Okay, this is very advanced tube. Okay, I will tell you. See, patient is suppose lying this side. Okay, you can see this is the head and this is the limbs. Okay, legs. Okay, so towards the head, that is the north facing, and towards the leg is the south facing. Okay, so this when we are using this and when we are using this. Okay, so this north facing tube are used. Okay, to the intranasal intubation. Okay, suppose if you are operating the buccal cavity or mouth, inside the mouth, if you are operating, okay, that is this tube is inserted through the nasal, intranasal intubation. Okay, intranasal intubation. Okay, suppose if you are doing the any oral surgeries, oral surgery. Okay, so that is called north facing. So this will be inserted as a nose. Okay, and this will be outside. Okay, it will be outside. So we are connecting the ventilator moving from here. Okay, to prevent the obstruction during the surgery. Suppose if they want to operate the cleft lip and palate. Okay, the south facing will be helpful. This is only oral. Okay, this is for the oral only. Okay, oral through oral they are inserting, but this is very advanced tube. This is already preformed. Okay, preformed means already bent. Okay, already bent, so there is no, suppose if normal tube, if you are fixing and if you are bending means, okay, if you are bending means it may kink right now. So to prevent that, this is already preformed, already bent. Okay, and directly we can connect the ventilator from here. Okay, so same here also same, this cuff will be there. Okay, here also cuff will be there. Okay, so here we are connecting the ventilator. Okay, this is oral and this is the nasal. Okay, that is clear now. Okay, we'll move on to the, so just we can see these are the RAE tubes. Okay, RAE means Ring, Adair, and Elvin. They are the scientists who discovered this ET tubes. Okay, endotracheal. So one more thing, don't forget, north facing always used for the intranasal and south facing always used in the mouth. Okay, we'll move on to the next image. Okay, this how we are measuring the ET tube sizes. 6 mm means. Okay, suppose doctors tell you, okay, bring the 6 mm ET tube. ET2 means how you will bring. Okay, so what you think? Okay, French is different. Okay, and so here gauge is different and French is different and also different. Okay, ET2 will be measured in the millimeter. Okay, see which one we are measuring. Suppose 6 mm means, say, inner diameter, always inner diameter. Inner diameter we are measuring that. Okay, that's why I'm telling you this inner diameter is a 6 mm. This outer diameter will be different, that is the 8 mm. See, this is the 6 tube. Okay, 6.0, okay, single use only. Okay, so here all 80 tubes they are mentioning that OD is the outer diameter is the 8.8. Okay, EID, okay, you can see ID will be inner diameter. Okay, so inner diameter will be 6 mm. Okay, don't confuse always. Okay, suppose if 8.0 tube means that is the inner diameter of the 80 tube will be 8 mm. Okay, now you clear. Okay, so one more thing will come, that is the armor tube. Okay, armor tube means, okay, spiral. Okay, so inside the tube there are spiral wires are there. Okay, tube will not be kinked. Okay, I will show you why it won't kink. See, inside reinforced, okay, reinforced armored tubes have been wire, okay, embedded in the wall. Okay, so like this wires are embedded inside the ET tube here. Okay, see here we can see some spiral marking. Okay, inside they have like a spiral they have made. Okay, suppose if you are bending also it won't kink. Okay, this is the advanced tube, so we call armored ET tube. Okay, and this is the standard one. So now we are, for all patients we are using the standard one only. Okay, for the special type we are using the armored ET tube. Okay, here it is there. Okay, how it is inside the coil, no? Okay, reinforced armored tubes have wire inside, they have wire. Okay, hope you clear. This is the cuff pressure manometer. Cuff pressure, this is the cuff pressure manometer. So why we are using this cuff pressure manometer? To measure the ET cuff. Okay, cuff whether we are inflated too much or inflated minimal. Okay, that we need to measure. So what is the normal ET cuff pressure? That will be 20 to 30 mmHg. So here we can see the green line is there. Okay, the green line is there, na? So that is the normal range of the ET cuff pressure. Okay, that much only we have to keep, otherwise it will injury to the trachea. Okay, so tracheal get injured. Okay, to prevent that we need to, okay, set cuff pressure only 20 to 30 mmHg. Okay, hope you understood now. See how we are going to check the cuff pressure means. Okay, so this is the ET2. Okay, so this is the ET2. Okay, so here pilot balloon will be there. Okay, pilot balloon I told you now. Pilot balloon we have to fix here. We have to fix the this pilot balloon here. After fixing, immediately this meter will show, okay, what is the pressure inside the cuff. Okay, if you want to release, we can release from this button. Okay, we can release the cuff. Okay, suppose if you want to inflate means we have to press this. Okay, we have to press this. Okay, then air will inflate. Okay, so this is very important, it may come in exam. Okay, then how we are measuring the size of the ET tube? Okay, this I don't want to explain more because everyone knows this. Just for the explanation of the formula only I have inserted the image. Okay, suppose if you are giving the uncuffed, okay, here it's already written. Okay, no need to write once again. Okay, suppose if you are giving the uncuffed ET tube, that is age plus 4 divided by 4. Okay, for the newborns we can give 3 to 3.5 we can give. Okay, that is for the uncuffed. Suppose if you are giving the cuffed means age plus 3.5 divided by 4. Okay, A is plus 3.5 divided by 4. That is the cuffed ET tube. Okay, for the uncuffed ET tube, A is divided by 4 plus 4. Okay, hope you understood. Okay, then how we are going to depth? Okay, so depth, how much we have to insert? So here we have given, okay, depth is equal to ETT into ET tube size into 3. Suppose if you are giving 4 tube, 4 mm tube, how much length we have to insert? I told you, okay, that centimeter will be there. Okay, at what centimeter we have fixed, that we need to note. Okay, so suppose 4 mm tube is there, we are intubating a baby. Okay, so at what length we need to insert? Okay, that is very important. That is the ET tube size into 3. Suppose ET tube size is 4 into 3 is equal to 12. So 12 centimeter we can fix the ET tube. So don't forget this formula, ET tube into 3. See, this is the Miller. Okay, try it. Miller. Okay, Miller Laryngoscope. Okay, this is the straight blade. Okay, straight one. And here we can see this is a Macintosh. Macintosh in small form we are calling Mac. Okay, this is the curved. For the pediatrics, we are always using straight blade. I will show how the curved and how the straight showing is the visibility of the trachea I will show. Okay, so straight always we are using for the pediatrics. Okay, this is curved always we are using for the adults. Okay, and this is one more, that is the McCoy. Okay, McCoy laryngoscope. This is the advanced laryngoscope. McCoy laryngoscope. Okay, so this, okay, this button is there, this rod is there now, we have to, okay, press this, then see here you can see it, some bend is there. Okay, so once we press this, okay, once we press this, okay, this will also bend. Okay, this is the advanced uh, laryngoscope. Okay, we are using for the adult patients. Okay, McCoy laryngoscope. Okay, so this is the image. Okay, this is the image how the straight blade and how the curved blade are giving the visibility. Okay, so this is the curved one, this is the straight one. So here we can see this is the straight blade. Suppose if you are using the curved blade, okay, we can see the, see this is, okay, vocal cords. Here we can see the vocal cords, but green line is the vocal cords. Okay, so this is the visibility of the curve and straight blade. Okay, so this is one more thing, video laryngoscope. Video laryngoscope. Okay, this we are using, this is advanced type. Okay, suppose if you are inserting, this means, okay, video device will be there. Okay, it is showing that whether you have entered correctly or not. Okay, so this is the video laryngoscope, very advanced one. Okay, it may come into the exam. Okay, this is the double lumen ET2. One more advanced double lumen ET2. Double lumen ET2. Okay, so here we can see this is the bronchial. Okay, so this is the tracheal. Okay, this is the tracheal and this is the bronchial. Okay, this we are using only with the chest surgeries. Okay, or thoracic surgeries. So this is the tracheal. Okay, so this is the, this balloon. Okay, this cuff will be inflated in the trachea, but this will be inflated in the bronchus. Okay, in bronchus it is inflated. So this one, See, this cuff is for the bronchus and this cuff is for the trachea. Okay, so only for thoracic and chest surgeries we are using the this type of double lumen ET tubes. Okay, this is clear. So suppose if this ET tube image come also, we can write that. Okay, and this is the ET tube. So same thing only I am telling. So for that reason, this is the catheter mount. Catheter mount we are using. Okay, here HME filter will be there. This will be connected to the ET tube. ET tube will be connected here. Okay, ET tube already in the mouth. Okay, this catheter mount will be connected to the ET tube. Why we are using this catheter mount means just this is the for the easy flexibility. Okay, then behind this is the very important image, HME filter. Okay, what is HME filter? HME means heat, moist, exchange, filter. Heat moist exchange filter. So this is okay. This will exchange the heat and moist. Okay, if suppose if any moisture comes from the tube or if any moisture comes from the patient, okay, this will prevent. Okay, and this will be replaced every 24 hours. Every 24 hours, we need to change the HME filter. This question was asked in the JIPMA skill test. Okay, this time maybe image based question it may come. Okay, so HME filter, heat moist exchange filter. Okay, this has to be changed every 24 hours. Okay, we'll move on to the next. Oh, this is the vein circuit. This is the vein circuit. Okay, see here we are connecting to the ET tube. Okay, from here we are connecting to the ET tube. This small blue line is there now. Okay, this will connect to the O2 source, oxygen source. This will okay work as like a reservoir come like ambu bag. Okay, this will come. This will act as like a ambu or reservoir. Okay, so this is the so we are connecting this tube. So when we are using this vein circuit, suppose we are shifting the patient from one department to another department, okay, or to the radiology, any other department. If you are shifting means, okay, this is very useful for that time. Okay, only so we can connect this to the oxygen cylinder, okay, O2 source, and this we are connecting to the ET tube. Okay, so very length will be there. This tube we are this green tube. Okay, we are holding in our hand. Okay, we are doing the ambu. Okay, so this is the vein circuit. Okay, don't confuse this. Okay, this is very important. Okay, cardiac monitor. Cardiac monitor, maybe they may give you the image and you just identify the parameters, because many of our candidates doesn't know what is cardiac monitor parameters, because they are freshers. Okay, they may not much exposure to the ICU and critical care. Okay, so here I will tell you, this is the okay, this is the ECG. Okay, it will show the heart rate. Okay, both. Okay, first and two. This one, okay, here we can see that is the BP 117 by 64. So here we can see this is the map, mean arterial pressure. Okay, so this is the arterial BP. Okay, arterial BP. Okay, and this is the SpO2. Okay, means oxygen saturation. This is the SpO2. Okay, and this is the, see here we can see this is the capnography, what we call EtCO2. Here it is there. 39 is the EtCO2. Okay, EtCO2, this is the EtCO2 waves. Okay, that is the 39. What is the EtCO2 normal? 35 to 45. Okay, so whenever intubated patients are there, we have to connect to the monitor, that is EtCO2. Okay, this is the VTCO2. So NIBP also is here. Okay, we can see here that is the cuff. Okay, we are checking to the arm. That is the NIBP we call, and arterial line. Okay, this is the different one. So this is the true BP we are calling. This is the anesthesia machine. Anesthesia machine. Okay. So suppose if they asked from the image based, we can answer this. Okay. Now very advanced LMS. Okay. LMS means laryngeal mask airway. Okay. LMA means laryngeal mask airway. Okay. Laryngeal mask airway. Okay. When we are using the LMS, whenever the difficulty intubation, for difficulty intubation time, we are using the LMS. Okay. This is very easiest one. Okay. So here we can see the different types of LMA. This is the LMA classic. Okay, they have already labeled here. So for your easiness, I am telling this. Okay, this is the LMA classic and this is the LMA unique. Okay, and this is the LMA Pro Seal, LMA Pro Seal, and this is the LMA Supreme. Okay, and this is the iGel. This is the iGel and this is the ILMA. This is also called fast track LMA. Fast track LMA. Okay, this is the fast track LMA. Okay, this is the iGel, this is the LMA Pro Seal, this is the LMA Supreme, this is the LMA Unique and LMA Classic we can see. Okay, and the most important one is the Mallampati score. Mallampati score when we are assessing, suppose this is also used for the sleep apnea. For the sleep apnea patients also you are using, and also to check the difficulty intubation. Difficulty intubation means we will check. Okay, there are four types of Mallampati score: class 1, class 2, and class 3. So, okay, the class 1 here we can see the class 1. Okay, class 1 is complete visualization of the soft palate and vocal cords. Also, everything is visible. Okay, sorry, only soft palate, not the vocal cord. Okay, vocal cord is inside. Okay, so here we can see the visualization of the soft palate. Okay, this is the good one, good condition for the intubation. Okay, then class 2 is there. Here class 2 is there. Complete visualization of the uvula. So this is the uvula. Okay, this is the uvula. Okay, so only that part only visible here. Okay, this is mild difficulty intubation. Okay, and class 3. Okay, so they may give you the, okay, they'll just give you the class 3. Okay, what you find, like that they may ask you. Okay, in class 3 what are the parameters you will see, in class 4 what are the parameters you will see, in class 1 what are the things you will see, that we need to identify. Okay, so class 3 we can see only the visualization of the base of the uvula. See here, only base of the uvula we can visualize in the class 3. Okay, how they are doing I'll tell you. Okay, and here we can see the class 4 only. Here nothing is visible. Okay, soft palate is not at all visible here. Okay, how we are going to assess means just ask the client to sit on the chair. Okay, and his neck should be free. Okay, and ask him to open the mouth. Okay, ask him to open the mouth. So by that time only we will ask, we will identify what is the class of Mallampati score. Okay, so Mallampati is he is the one who discovered the score. Okay, Mallampati score is the class 1, class 2, class 3, and class 4. There are 4 classes in the Mallampati score. Okay, and one more score is there, that is the Cormack-Lahane grading system. Okay, that is the Cormack-Lahane grading system. Okay, grade 1, grade 2. Here also grade, there are 4 grades are there. Okay, in grade 1 we can see the epiglottis and also vocal cord. Okay, this blue color we can see now. Blue colors are there, that is the vocal cord. Okay, vocal cord. Okay, in grade 1, okay, entire laryngeal aperture and also this vocal cord also visible in grade 1. But in grade 2, only posterior portion of the laryngeal aperture is visible. Okay, in grade 3 only epiglottis is visible. Here only epiglottis. See here this is the epiglottis. Only epiglottis is the visible in the grade 3. Here in grade 4 no structure is visible. Okay, this is the 4-mark Lehane grading system we call. Okay, this also they may ask you in the exam. Only just giving you the this one description and ask you which grade, or they may give you the grade and ask you to tell the description. Okay, so one more thing. Okay, this is the try Sellick maneuver. Okay, this is the Sellick maneuver. Sellick maneuver. Why we are using this Sellick maneuver? Okay, just see, trichoid cartilage will be there. Okay, patient will be lying on bed. Okay, we have to give the pressure. See here we can see this is the esophagus. Okay, suppose if you are pressing this, okay, it will block the esophagus to prevent the aspiration. To prevent the aspiration, we are using the Sellick maneuver. Okay, during the intubation. Okay, during the intubation, we are using this Sellick maneuver. Okay, suppose if they are giving this image and ask you what it is, we have to tell that this is the Sellick maneuver. Okay, and here we can see, okay, cannula has come. This is the arterial cannula. Arterial cannula. Okay, so for the access of the arterial BP. Okay, to measure the arterial BP, we are inserting this arterial cannula. So this is the advanced one. Okay, we can lock the backflow. Okay, so for this reason only, this is the push and pull manner will be there. Okay, so it will block the artery. Okay, okay. Then how we are going to measure the arterial BP? This is very important point. This is the plebostatic axis we call. Okay, plebostatic axis. So where is the plebostatic axis? They may ask you in the exam. That is the fourth intercostal space. Fourth intercostal space, mid axillary line. Okay, so this is the see here we can see this is the mid axillary line. This is the fourth intercostal space. So this is the plebostatic axis. Okay, so this is the arterial line. So this is the monitor. Okay, this is the uh, pressure bag. This is the pressure bag. Okay, why we are using the pressure bag? For the arterial BP. Okay, to prevent the backflow. Okay, it will push the blood inside, and also transducer will be here. Okay, transducer we are fixing here. Okay, both should be in a line. That is the see transducer mid axillary line. It is there, and also plebostatic axis and hand is also same position. Okay, this is the plebostatic axis. Patient should be lie down supine. Then we are making the zeroing of the arterial line. Overall working in ICU settings, they might know, okay, how to zero the arterial line. Okay, and one more thing, this is the spinal needle. Okay, this is the spinal needle. Okay, for the lumbar puncture. Okay, you're using for the LP needle also. We can call LP needle. Okay, spinal needle. Okay, this is the Tuhoi needle. We call Tuhoi needle. This is used for the epidural access. This is for the lumbar puncture LP. Okay, spinal needle, and this is the Tuhoi needle. So here we can see the wings. We can differentiate easily. Okay, so this needle and this needle. This is the Tuhoi needle used for the epidural access. Okay, now we come to the this is nasopharyngeal airway NP, nasopharyngeal airway. Okay, nasopharyngeal airway. There numbers are there. Okay, so and this is the Goodell airway. Goodell airway, for also called oropharyngeal airway. Oropharyngeal airway, OP airway or Goodell airway we call. Okay, so numbers are there. Okay, most commonly using is number 2 for the adults. Okay, number 2 is green. Okay, maybe they can ask you, okay, which number is which. Okay, number 2 is always green. Okay, yellow is number 3. Okay, and red will be number 4 and orange will be number 5. Okay, size 1 will be white. Okay, size 2 will be green. Okay, then size 0 is the black and size uh, 00 is the blue. Okay, we can see that. Next we'll come to the oxygen delivery devices. Oxygen delivery devices. So oxygen delivery devices, this is the nasal prongs. Nasal prongs. So minimum oxygen how much we can keep here is the 1 to 6 liter per minute. 1 to 6 liter per minute. Approximately it delivers the oxygen 24 to 44 percentage more than room air. Room air oxygen will be 21 percentage. Room air oxygen will be 21 percentage. So this is the nasal prong. Okay, minimum 1 liter to up to 6 liter we can deliver the oxygen. So percentage, if you come to the percentage means it will deliver the 24 to 44 percentage. Okay, this is the simple face mask. Simple face mask. Okay, this is the simple face mask. Okay, this minimum oxygen should be 6 to 10 liter. Suppose if patient required more than 6 liter of O2, we need to use the simple oxygen mask. Okay, simple oxygen mask, that is the 6 to 10 liter per minute we can use. The O2 percentage will be 35 to 60 liter. 60%, 35 to 60% it will deliver the oxygen. Okay, this is the high concentration mask or high concentration mask, or also NRBM, non-rebreather mask. NRBM we call. Okay, that is the non-rebreather. Non-rebreather means what? Okay, see, we are connecting this to the oxygen source, and oxygen will come will be, it is a reservoir. Okay, oxygen will be settled here. Okay, oxygen, this is the oxygen reservoir. Okay, here the exhaust valve will be there, both sides. Okay, so whenever patient is taking the breath, oxygen will flow inside. Okay, patient only take the oxygen. Okay, here one valve will be there. Here one valve will be there. Okay, inside. Okay, patient whenever exhaling, that time this valve will be closed. Valve will be closed. Only exhalation will be from here. Okay, then automatically it will close. For that reason only we are calling it as a non-rebreather mask. Once exhaled air, okay, patient cannot take back to the inside. Okay, so oxygen will be here. Okay, oxygen will be here. Whenever patient inhaling, the oxygen will go to the inside. Okay, whenever exhaling, this valve will be closed. Okay, this valve will be closed. Only exhalation will be happen in this holes. Okay, so hope you understood now. So that's why this is called non-rebreather mask. Rebreather mask also will be there. Partial rebreather mask will be there. Okay, partial rebreather mask. Okay, some amount of air will come to the bag. Some amount of the air, exhaled air will come to the bag. Again it will goes to the patient. So that is partial rebreather mask. Completely rebreather mask are there, that whenever you're using for the hyperventilation patients, that we are using for the hyperventilation patients. Okay, or else we can give plastic cover also. Okay, some patients, some especially some girls during the exam results, okay, or any panic moments we call, okay, so we need to give carbon, some of the carbon dioxide, okay, to maintain the normal respiration. Okay, during the hyperventilation we are using the rebreather mask. Okay, and this is the venturi mark, venturi mask. Here we can see the color codes. Okay, green, red, white. Okay, green, red, white, yellow and blue. Okay, so I'll write, okay, here venturi marks this up to precise accurate oxygen it will deliver. Okay, so I will tell you here. First one is the blue. Blue is the 24 percentage. Okay, blue is the 24 percentage. How much it will oxygen we need to keep? That is the 4 liter per minute we have to keep. And next one will be the white. White will be delivering the 28 percentage of oxygen. Okay, for that we need to keep same 4 liter per minute. Okay, and then next orange. Next will be orange. Okay, so that delivers the 31 percentage of O2. Okay, for that we need to keep 6 liter per minute. Okay, and next will be the yellow. Yellow will be 35 percentage. Okay, for that we need to keep 8 liter per minute. And red, okay, red will be 40 percentage. For that we need to keep 8 liter per minute. Okay, and last will be green. Okay, it will deliver the up to 60 percentage of O2. Okay, that will keep 12 liter per minute. Okay, suppose if you want to see, if you don't have high concentration mask, or if you don't have simple face mask, you need to deliver only 24 percentage. See here we have to remove this. See, that's why I inserted one more image. This we need to remove, and we can, suppose if you want to deliver the 24 percentage oxygen, we can insert this. If you want to uh, if you want to deliver 28 percentage oxygen, okay, we can insert the white. We have to remove this and we have to insert this. So this is the process. And here this is, okay, HHFNC, H H H F N C, that is the heated, okay, humidified and high flow, okay, nasal cannula. Heated, humidified, high flow nasal cannula, HHFNC we call. Okay, this is, okay, it will deliver the 100 percentage of O2. Okay, 100 percentage, 21% to 21 to 100 percentage of O2 it will deliver. Okay, this is the HHFNC we call. Okay, so Airway 2 like that you can see in your departments. Okay, Airway. And one more thing, this is a NIV mask. Okay, for CPAP, NIV means non-invasive ventilation. Okay, CPAP or BiPAP. Okay, difference between CPAP and BiPAP, Nagaraj sir will take. Okay, so don't worry. So this only image based questions only I am asking you. Okay, so if you have any doubts, you can also ask in WhatsApp. Okay, so thank you.